Good morning, ladies and gentlemen, and welcome to the early recognition of sepsis in the outpatient setting, the role of home health care for improved patient outcomes, Part 4, conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Mr. Al Cardillo, you may begin the conference.
Thank you very much. This is Al Cardillo. I'm the Executive Vice President of the Home Care Association of New York State. I am present today with Sarah Butterfield, who's the Senior Director for Healthcare Quality Improvement at IPRO. She's also a member of the HCA Quality Committee and our Sepsis Work Group that led to the development of the tool. And on the line with us is Amy Bowerman, RN. She's the Director of Quality Improvement for the VNA of Utica in Oneida County. She's also the Director of Patient Services for the Senior Network Health. She's a member of the HCA Quality Committee, and she was the leader of our Sepsis Work Group. I want to begin by thanking everyone for participating in this, the fourth of the series of webinars that we've done on the Sepsis Initiative. We know that there's obviously a major nor'easter that's striking a good part of New York State, especially the downstate area. We are being hit pretty bad just as we speak right now. But I think that the home care field is one field that even exceeds the Postal Service, that neither wind nor snow nor rain will in any way deter the delivery of home health services in the state. The home care workers are tough, and you always prove your courage and your ability to come through despite any circumstance. And that's not just said in jest, it's really said very sincerely. We appreciate everything that you do, and particularly when you have to deliver care to individuals in the midst of an emergency, or certainly in the midst of so many challenging conditions that you do. So thank you for everybody that's here now. There will be a situation where the webinar will be available on recording after the webinar is completed, and so for those that were not able, certainly, to make this webinar because of the treacherous conditions, there will be an opportunity still to in effect, to participate. So as I mentioned, this is the fourth in the sequence of webinars IPRO conducted, and thank you, IPRO, for hosting all 4 of the webinars. These webinars are preparatory to the official release of the sepsis tool. This webinar is a train-the-trainer session for agency representatives who will in turn train their agency's home care clinicians in the use of the sepsis screening tool and the accompanying protocol. Today's webinar will the protocol. The webinar will also provide some additional guidance to assist trainers in conducting training for your agency staff, as well as training for agencies that may need or wish to conduct with key clinical partners, so physicians, hospitals, nursing facilities, EMS, and others. The training today will help you as you need to convey, some of this critical information to your partners as you implement the Sepsis Initiative. So the opportunities for questions and discussion, including considerations that would be helpful on the agency adoption, implementation, and EHR integration of the tool and protocol. What we will do is to ensure that there's time to get through each of the respective issues. We will stop and prompt at various points for questions and discussion. Webinars 1 through 3 are prerequisites for this seminar, and 1 through 4 are prerequisites for HCA authorization of agencies to use the tool upon official release by HCA. Webinars 1, 2, and 3 are already recorded, and they're available at the link that you see in the webinar, and that will also be provided to you through other communications so that you have it live. the U.S. Centers for Disease Control and Prevention has also posted the HCA iPro webinar series to its sepsis clinical tools page under education and training. And if anyone who goes to that link can also link back to the webinars. It's a really great, I think, validity of the effort that we're undertaking, and I think that all of you will be undertaking and implementing the tool. Today's webinar, as I mentioned, will also be recorded and will be made available. So, plans for availability of the tool. So, HCA plans to make this tool available to agencies imminently via user agreement with agencies, and the user agreement is nearly finalized. The agreement is intended to facilitate quality through trained and standardized use, adherence to form and accompanying protocols, participation in data sharing, and several other criteria that we think is important for individual agency use and for the statewide implementation of the tool. More on both of these items will be discussed in the section following the train-the-trainer portion of the webinar. HCA and iPro will also announce plans to further assist implementation through supports like technical assistance office hours, periodic statewide calls with users, a process for submitting questions, reporting on collected data, and others. Our assistance plans are also being finalized, and they will be further announced as we circulate the tool itself. I'm now going to move right into the train-the-trainer session, which will also include the presentation of the sepsis tool and the protocol. And for this session, I would like to introduce to you Amy Bowerman, the Director of Quality Improvement for the DNA of Utica and Oneida County, and also, again, member of HCA Quality Committee and the HCA Sepsis Work Group leader. Amy?
Good morning. The format for this section of this webinar is the presentation of our tool and workflow and the presentation of the protocol. I will periodically stop through with questions and answers throughout. I will review 4 case scenarios, and then we can also go through some questions and answers throughout the scenarios. Again, the scenarios are certainly not always black and white, keeping it in mind as we go through them, but it will give you a generalized ability to answer the sepsis screen tools through the scenarios and some of the original things that may pop up within the home care arena. Discussion of additional training and agency adoption and implementation and guidance. Next screen. This is just a reinstatement of the authorization used from HCA. Next slide. Here's the sepsis screen tool. This is the adult version of the sepsis screen tool. Date with any of the enhancements from the feedback that we have received. Next slide. Okay. The sepsis screen tool was developed to assist in streamlining clinicians' assessment and recognize the clinical signs and symptoms of sepsis in a post-acute setting such as home care. The sepsis screen tool is a set of the sequence of 3 questions. The questions are based on the assessment. The screen tool can easily be answered by a clinician doing a routine head-to-toe assessment. The answers are based on clinical findings, and once all the questions have been answered, the screen tool provides the clinician with the information to determine if the patient meets sepsis criteria or if a patient is at risk for sepsis. This is the algorithm for the sepsis screen tool. This should be utilized as their reference guide. Next slide. Here are the prompts for determining whether or not the patient has sepsis criteria. Question 1. Does the patient's history, physical exam, or other findings suggest an infection or potential source site of infection? This question is answered by the clinician gathering data of the patient's past medical history, surgical history, and the clinician's physical assessment. There are some suggestions provided on the screen tool, but this is not all inclusive of the possibilities. Some of the obvious source sites of infection are Foley catheters, immunocompromised patients, and open wounds. The purpose of question 1 all the possibilities of potential sites of infection, not just an active infection. Number 2, systemic criteria. Are there any 2 systemic criteria present? A clinician measuring a patient's vital signs and assessing the data is how this question is answered. Does the patient have a fever? Are they hypothermic? Is the patient tachycardic? Or is the patient tachypnic? The answers are based on the objective data obtained from the patient during the clinician's physical assessment. Remember, the patient needs to have 2 of the systemic criteria present. Question 3. Is there at least 1 new onset of sepsis-related organ dysfunction criteria? The key point to this question is new onset. So patients who have a baseline of an organ dysfunction would not be answered yes to this question. So someone who is currently receiving dialysis, they would not have a new onset for kidney dysfunction. The clinician's assessment for their neurological, cardiac, respiratory, GI, GU, and pain will provide the data to answer this question. Next slide. Once the clinician has completed all 3 of those questions, the clinician can then progress to the follow-up area of the provides guidance for the clinician to determine what type of follow-up the patient requires based on the answers to the questions of the first 3 questions. It is important that a clinician follow the direction of the follow-up items as indicated, keeping in mind that the clock is always ticking when it comes to sepsis. Once the clinician has completed their follow-up, they will need to document in the patient's medical record the follow-up that is completed. If a doctor provides a telephone order when a clinician is notifying a physician, the nurse will need to document a doctor's order that will need to be sent for the doctor's signature. The sepsis screen tool is not used as standard doctor's orders. Next slide. Next, the clinician would then move to the interventions area on the screen tool for suggestion of appropriate interventions for the patient. These interventions are not all inclusive of what may be done. A doctor may order an intervention that is not on the screen tool. You would just document your intervention in the appropriate area in the patient's record, or they can document in the text box provided on the tool. The sepsis screen tool is an SBAR tool, and it may be sent to a provider for communication as appropriate. Once all of the areas of the screen tool are completed, and the clinician has completed their follow-up, it's important to ensure that all documentation is completed to reflect the care that has been provided to this patient. Clinicians need to take credit for all the good care that they provide to a patient. Document, and document some more. Next slide. And this is just the flow chart of the interventions and follow-up. Next slide. Next slide. Patient education is key to sepsis. Many people understand the signs and symptoms of a heart attack, and they understand even the signs of stroke. However, patients do not know the signs and symptoms of sepsis. The early signs and symptoms of sepsis zone sheet is designed to educate patients of the signs and symptoms of sepsis. Many people have never heard of sepsis, nor can they state signs and symptoms of what a person should do in the event that they develop signs and symptoms that are indicative of sepsis. Zone tool provides a person with information of what the signs and symptoms are and what to do in the event that they develop any of these signs and symptoms, and it's easily understood. It is intended for the sepsis zone sheet to be utilized with the patient for education and be left in their homes as a reference guide for not only the patient but the clinician as well. This is the sepsis protocol that has been developed to mirror the sepsis screen tool. This is the full two-page document on this slide, and I will break it down and go through it with you. Next slide. The first key point to the protocol is the purpose of it, and the purpose being the guidance for utilization of the sepsis screen tool. The scope, who can complete the tool and when, and that's all licensed clinicians, and it's at every home care visit. References that were utilized in order to develop the screen tool and the protocol. Definitions and abbreviations utilized throughout the protocol. Instruction elements throughout the screen tool. Next slide. In the screen tool questions, the protocol gives guidance as to how to answer the questions as well. And those are questions 1, 2, and 3. Next slide. Your follow-up in the protocol. Next slide. As well as your interventions. Noting in the blue, the protocol notes that the tool may not be used as standing orders, and it also notes the protocol for electronic health record utilization, and that there may be some variation with electronic health records. However, the questions, the content, and the sequence of the responses should not be altered from the original paper form. It also addresses the education use in the protocol, requiring the use of the tool. And as Al had mentioned previously, the agreement is almost finalized. Next slide. Does anybody have any questions in regards to the sepsis protocol prior to moving on to patient scenarios?
Grace, could you prompt folks on how to answer questions, please? Ask a question?
Yes, definitely. So, ladies and gentlemen, in order to ask a question, please press star, then the number 1 keypad. Again, that's star, then the number 1 on your telephone keypad. Let's pause for a second to compile the Q&A roster. Speakers, we don't have any question at this time. Please continue.
Okay, thank you. A 9-year-old female admitted for nursing care for a diabetic foot infection. She is receiving IV antibiotics via PICC line. She is seen 3 times a week for dressing changes to her foot wound, assessment of her wound, and an assessment of the maintenance of her PICC line. The patient's wound has been progressively healing with improvement in appearance and decrease in the size of her wound. Her vital signs are: her temp is 98.4, pulse 72, respirations 18, and her blood pressure is 116/70. The patient is alert and oriented times 3, breathing is easy, and denies any pain. Her skin is warm, pink, and dry, denies any complaints with bowel or bladder functioning. From that history and physical assessment, the question number 1 is answered yes. The patient has an active infection. She has a diabetic foot wound. The patient also has a sore site for potential infection. She has a central line. Question number 2. The patient does not have any systemic criteria. Her vital signs are all within range. Question number 3. The patient does not have any signs or symptoms of new onset of any type of organ dysfunction. The follow-up would be not meet sepsis criteria. The patient was educated on the signs and symptoms. Next slide. Scenario number 2. A 91-year-old female admitted with COPD pneumonia with possible aspiration and confusion related to dementia. The patient has a history of urinary incontinence. The patient has a supportive daughter in the home who is her primary caregiver. Upon assessment, the nurse determines that the patient has a temperature of 96.6, a pulse of 110, respirations of 26, and a blood pressure of 101/60. The patient is holding her stomach and stating her stomach hurts. The daughter reports that her mother has been more confused over the last day and that her urine seems to have a strong odor to it when she is caring for her. Question number 1. Yes, the patient has a potential source site of infection with incontinence and a history of potential aspiration pneumonia. 2. Yes, the patient has 2 systemic criteria. The patient has a temperature that is outside the thermometer, she is hypothermic, and she is tachycardic. Question 3. Yes, the patient has a new onset of abdominal pain. For follow-up, all 3 questions have been answered yes. The patient meets criteria for severe sepsis. The patient requires immediate treatment. The MD is notified. The patient is transported to the emergency department. This last step of reporting to the receiving emergency department is very important. That care coordination piece is so important in order to ensure that there is no delay in this patient's treatment. Next slide. A 65-year-old male admitted for diabetic teaching due to being new on insulin. He has a history of pneumonia and coronary heart disease. The patient's wife is in the home who is supportive. Upon assessment, the nurse finds a reddened area to the lower right leg. The patient has a temperature of 99.6, a pulse of 100, respirations of 22. Their SpO2 is 98%, and a blood pressure of 120/68. The patient has no complaints of pain or any GI or GU issues. As we complete the sepsis screen, we answer question number 1. The question to number 1 potentially is yes. The patient has a potential source site of infection with area to his lower right leg. Question 2 is yes. The patient has 2 systemic criteria. The patient is tachycardic and the patient is tachypneic. Keeping in mind that the patient does not fall into the parameter for a temperature, but is very close to it, running at a low-grade fever. Question number 3 is no. Function. A follow-up would be is that the patient meets criteria for sepsis with questions 1 and 2 are answering yes. The doctor is notified and an order was obtained for a CBC. The doctor also, in the interventions, has initiated IV or antibiotic treatment. And the next skilled nursing visit will be completed within 24 hours. Very important for the follow-up. If IV or by mouth antibiotics are initiated in the home, this sepsis treatment is generally very aggressive. However, this patient does not meet severe sepsis criteria at this point. It is very important for the nurse to follow up within that 24 hours and make sure that this treatment that the doctor has initiated in the home is effective for that patient and ensuring that the patient is not deteriorating with that initial treatment. So that 24-hour visit is very important for that follow-up. Next slide. Scenario number 8-year-old female admitted with new onset of congestive heart failure. The patient has a baseline mentation of being alert and oriented. The nurse has been completing congestive heart failure teaching with the patient over the last few visits, and the patient has been completing all the follow-ups that the nurse has instructed her to do, such as monitoring her daily weight. At today's visit, the nurse's assessment is as follows. Temperature is 98. Aspirations are 18. Her SpO2 is 98%, and her blood pressure is 134/78. Bilateral lung sounds are clear, does not appear to be in any type of discomfort. When the nurse asks the patient if she has any pain, she appears to be confused. Is unable to answer the question. As the nurse continues with her assessment, the nurse notes that the patient has a new onset of confusion, but does not have any facial drooping or unilateral weakness. As the nurse completes the sepsis screen, for question number 1, the first question is no. The patient does not have any noted infection or potential source site of infection. Question 2, no. The patient does not have any systemic criteria. All of her vital signs are within parameters. Question 3. The patient does have a new onset of an organ dysfunction. The patient has a new onset of confusion, which is not her baseline. The follow-up would be is that the patient meets criteria for NV notification. We must report that this patient has a new onset of confusion, which is not at her baseline. The intervention. The doctor was notified by the nurse, and the doctor requested to see the patient in his office after the nurse reported off. Transportation arrangements was made and with the family member to take the patient to the doctor's office. I selected this intervention as part of the scenario to show that not all of the interventions that are listed on the screen tool is what happens. So that's why the text box was added so that this could be documented either in the text box for an intervention that isn't listed, or it can be documented in the patient's medical record, whichever, however the agency determines is appropriate for the documentation place. Next slide. Additional guidance for training and agency adoption and implementation. Clinician training should include review of all the webinars and case scenarios to ensure clinicians completion of the screen. Clinicians should ensure completion of the screen tool on every RN assessment and clinical visit, unless it is contraindicated by a physician's order. We will invite initial feedback rounds after the first several weeks and months of implementation to ascertain any important clinical or procedural questions and ensure consistency, accuracy in the screen completion, offer any type of additional in-services as needed. Your feedback when utilizing the screen tool is helpful to us. We have made enhancements to the screen tool from the feedback we have received. Next slide. Updates to clinicians on sepsis development. Considering the sepsis teaching as an annual in-service for staff competencies, and considering supplemental trainings perhaps, this alliance with Thoughton Foundation, CDC, and others. We ask the adoption of the sepsis protocol within agencies' policies and procedures. Incorporation in agency quality assurance and improvement committees for review of the process. Incorporating into an agency's electronic health records. We know that clinicians prefer to document electronically now. Years ago, nobody wanted to leave paper, and now nobody wants to go back to it. So certainly support there for any type of implementation. Evaluation, tracking of outcomes, feedback for potential improvement, and outreach, training, and education of your clinical partners, such as your physicians' offices, the hospitals, and your EMS. I would encourage everyone to let your primary care providers that you work with, and as well as your emergency departments that you routinely send to, and your EMS, know when you are implementing the sepsis protocol and screen tool utilization. It is important that the emergency departments understand that you are all as they are as well. So when a nurse is, or if any clinician is calling in with report, they should be automatically setting off a sepsis alert for that patient that's coming in. This prevents any type of delayment in treatment. Next slide.
Amy, thank you very, very much. Could we just prompt to see if there are questions based on the case scenarios or this review of guidance, additional guidance that Amy just covered?
Sure, no worries. So, ladies and gentlemen, in order to ask a question, please press star, then the number 1 on your telephone keypad. Again, that's star, then the number 1 on your telephone keypad. So the first question that we have comes from the line is Ms. Catherine Ruiz. Please ask your question.
In the tool, it indicated that any clinician can perform this home care sepsis tool. But then in one of the slides it says the RN assessment. Can our physical therapist also do the screening tool? As in our agency, our therapists have sent patients to the hospital.
Yes. I did happen to see that slide. It says assessment and clinical visit. So we do mean when we say that any licensed clinician can complete the sepsis screen tool, keeping in mind that LPNs will need oversight if they are they certainly can gather that data.
Thank you.
We have another question coming from the line of Joanne Raker. Please ask your question.
Yes, I have a question in regards to primary physicians, and those are who we primarily work with. What type of education has gone out to them about sepsis? We know that gaining their support on any initiative is very important for the success. So I was just trying to figure out what education has gone to them.
I can
Sarah,
answer.
do you want to take that?
Yes, I'll take that. So that's a great question, and it really is a setup for what we're trying to do more broadly on the association level. I will speak to that in a little bit, but so one of the things is that we've already started outreach to the State Medical Society to advise them, bring them up to speed on the status of this initiative. We'll be looking to seek their support in getting information out to all not only their physician memberships, but all the county medical societies. We are similarly doing outreach to the hospital associations and again broadly to all of the various state networks that would help inform. That really is intended to partner with what agencies also need to do at your own local level to get the information out to the physician community. But we will be doing that at the state level. We'll also be reaching out to the state health department in terms of the efforts that they have right now to advance primary care practices. So the state is developing this very wide-scale initiative to bring up to an advanced level primary care practices throughout the state, and this would be information that we would seek to also introduce into that process.
And I just wanted to add, Amy, this is Sarah, the important point that Amy made with regards to this protocol crosswalking to what the hospitals already have, a mandatory protocol in place once patients arrive in a New York State emergency department with the signs and symptoms of sepsis. And Amy, can you just address how this crosswalks to what they need to do?
Yes, when the emergency departments in 2013, the New York State Department of Health mandated that the hospitals have a protocol in place for sepsis. And the departments are screening every person entering the emergency department with similar questions that are utilized on the tool. So it crosswalks the same type of questions. Their protocols are a little differently because they have more access to different things that they're able to do as far as treatment-wise goes than in home care arena. But those identifiers that we have utilized absolutely crosswalks the emergency. For sepsis would be triggering the emergency department to alert a sepsis alert. So once somebody is identified in the emergency department as potentially for sepsis, they send off what is called a sepsis alert. And that's generally a team that immediately starts treating that patient. Again, keeping in mind that time is always ticking when it comes to sepsis, and that early recognition and that early onset of treatment is really what saves lives.
Thanks, Amy.
In addition to the outreach areas that I mentioned, we are maintaining our collaborative partners in this entire process of the National Sepsis Alliance, the Stoughton Foundation, the CDC, and collectively we will be working and continuing to work in relation to outreach to all the key partners in the community, including the physicians. So, I mean, your question is really right on the point, and really cues up an area that we will be following up as aggressively as we can.
Do we have another question, Grace?
Yes, so the next question comes from the line of Kelly Latin. Please ask your question.
Yes, I was wondering how we would get these handouts that you guys are teaching on us.
Well, they'll all be made available. So the webinars are all available. The materials are available, downloadable through the webinars, but we can also make hard copies of all of this available to all the ultimate users of this. And I think that what we will also be doing is we'll be looking to continue to make additional resources that are helpful. One of the things that Amy talked about on the education side and the training side is kind of continuing resources made available to agencies for this, and that'll be the subject of our discussions with our partners.
We have another question coming from the line of Heidi Blackford. Please ask your question.
Hi there. Yes, I had a question as far as one of the interventions of collecting a CBC. Is it recommended best practice to have a standing order from the physician on the point of care, or would you encourage to ask for the CBC collection when you contacted the physician when you identify that there is a possible sepsis?
I think that would need to be determined at agency to agency. You may find that if you put it on your plan of care, your physicians may automatically want the CBC. However, you may find other physicians may say, I don't want that. So it depends on those particular physicians. Sometimes that's always kind of a crapshoot as to what they're going to do. So. But you certainly could put it on your plan of care. If they're signing off on their plan of care, then those are the orders.
Okay. Thank you.
Yeah.
The next question comes from the line of Melinda Martin. Please ask your question.
Good morning. Our question comes regarding our triage and urgent responding team. If this screening tool should be initiated through a phone call. We have services available to our patients, and in the event that we do through a telephone call to initiate the screening tool.
I think I would have to actually walk it through as far as going through telemedicine. To be honest with you, that is not a current thought of practice as far as what we have recognized on the screen tools yet, so that is something we would have to actually walk through to be able to give an accurate answer to that, and certainly we would have to reference the physicians on that.
Okay, thank you.
The last question that we have comes from the line of Roberta Aiken. Please ask your question.
I'm wondering if there's any plans in place for including paraprofessionals in these protocols.
As far as nurse practitioners,
No,
or are we looking at home health aides?
Pardon?
Who are you referring to as
Aides. And so as far as the training for identifying signs and symptoms and the protocol for follow-up.
So
Sarah, I'll pass that one to you.
So this is Sarah. I think for sepsis overall, we have a community-based sepsis program up and running, and what we did was focus on the clinical and non-clinical staff. I absolutely think that the home health aides, the paraprofessionals that you're referring to, every staff member should know the signs and symptoms of sepsis. And I think that tool that Amy showed you, the zone tool, is one of those things that could be shared with them. And there's also posted to our StopSepsisNow.org website a brochure that goes through, you could use that, You could use the zone tool. Both of those are excellent educational tools at the public level that people would understand. So I think those are two recommendations for tools to educate the home health aides as well, and the rest of the staff within the organization.
One related piece too is the fact that so this was a point I was going to get to later, but I'll gloss over it then. So the Department of Health ready to initiate a $245 million training and education program that will largely be applicable in home health. They've been negotiating back and forth with CMS for probably a year on the format of this, but it's pretty close to being finalized. So one of the areas that we recommended be included for training, and this would certainly include the paraprofessional, is sepsis early identification and intervention in home care. So second, what Sarah said and reinforced, I think the home health aide can play a very critical role in looking out for signs and symptoms and reporting that back to the agency, to the clinicians when they see it. And we would look to support that. I mean, we would look to support that not only through that grant, but through other education and outreach and training activities that HCA can conduct as we move forward.
And it's I think. Oh, go ahead.
No, I was just going to say I think it's a really important piece around the home health aide who, as you said, plays a critical role because they're generally in the home with the patient for, the longest period of time.
Absolutely.
Absolutely.
And this is Sarah again. I'm just thinking we have a non-clinical community-based sepsis training PowerPoint presentation that we can post to the StopSepsisNow.org website. So if you wanted to do that, it's a ready-made presentation to share with them. If you were doing a competency or just something over lunch training, one of those. So
excellent. That would be great.
We'll post that within the next week.
Are there further questions in the queue?
Not at this time, sir. So you may continue.
Thank you. I would like to compliment all the questions that were raised. Those were really, really excellent questions, and they really, kind of allow for, the discussion to get more detailed in some of these areas. I also would like to go back to the question that related to telehealth, and then sort of add this to that discussion. I think as we go along, we're going to discover areas that might not have come to our increasing experience. There will be ideas that relate to perhaps more functional or more penetrating use, or perhaps challenges that we see as we're putting this in place. It's our intent to really have a feedback and evaluation loop continuous, and certainly with the intent that where there are ideas for applying this in ways that have not been foreseen to date, we can visit those and offer guidance and assistance in that realm. And I would, certainly would include the telehealth component of that, especially when we're dealing with individuals in situations where telehealth is already in place, it's providing ready information, and may signal the need for some type of intervention. Maybe it's a visit to complete the screen, or maybe it's some other type of intervention. So I just think it's all of these items in the queue have been very, very valuable, and we intend to continue that process. So let me move to the next steps in the process. So as we mentioned earlier, HCA is preparing a user agreement that we referenced in the earlier slides. It's already drafted. What we really want to do is we want to review the agreement with clinical and agency representatives of our quality committee and our sepsis work group to ensure friendly for the users. And in particular, there are some references to the EHR integration, et cetera. We just want to make sure that there's nothing in the agreement that is in any way a challenge or an obstacle or problem for any folks that are using the tool. The second thing in terms of provision of the tool, and this is also in part in response to a question that was asked earlier, We intend to make the actual useful versions of the tool, the flow chart, the written protocol, and any related information available to all the clinical users. What you really had throughout the webinars are really just screenshots to support the dialogue, and so that you can see exactly how the tool is formatted and structured. The other thing that's very important is that we are also synchronizing this effort with the Department of Health. So we've discussed with the Department of Health synchronization with both their central office and with regional offices and surveyors. So we want the surveyors and the central staff all knowledgeable, not only about the implementation effort, but really about the details of the tool. So if there's a surveillance visit or if there's a discussion, we want to make sure that everybody is really up to speed on the origins of the initiative, its goals, and certainly its use within agencies. We will be providing the tool and the protocol in a formal way to the Department of Health, indicating that HCA intends a statewide launch. And our planned next step with the department is that the department would sponsor a webinar that we would conduct, HCA and IPRO would jointly conduct for the central GOH staff and for the regional representatives. So that would be our plan going forward. And the efforts of the health department to support this initiative. I go back to the initial webinar that we held where we had participation by Becky Gray, we had participation by Pat Ruhan, who's the director of the Office of Patient Quality and Safety and really heads up the sepsis initiative in the health department. And we also had participation by the governor's Health and Human Services Secretary, Paul Francis. We could certainly not ask for more robust support from the leadership on the health side, and we will continue to tap that and encourage that as we go forward, because I think that's very important in continuing to validate this whole effort on the part of the home health community in New York State. The next piece is implementation support. And HCA and IPRO have talked about a planned series of steps that we could take. I referred to them in the earlier slides, relating to technical assistance and office hours, periodic statewide call-ins to review our experience, collection of data and sharing of data with you all. So that's something that we plan to roll forward with. And I think especially in the earlier periods, this will be very, very valuable in providing feedback. I think it will also be very valuable in terms of further benefit of what we're doing here, because clearly in the changing environment, whether it's the district system, the value-based payment system, managed care, or just the broader attention to performance metrics in healthcare for quality outcomes, the information that's generated in this initiative, we hope will be very validating of this effort and for all the agencies that have taken this very pioneering step in the process. As Amy characterized the tool as being an adult sepsis screen, the tool was really constructed for adult screening. We've initiated contact with individuals who are doing work in terms of pediatric sepsis, and we'll be exploring next steps in terms of either the applicability of this tool or whatever modifications would be necessary to support the use of or the conducting of screening in the pediatric community. Further steps also include continued collaboration with key partners, and we mentioned earlier the National Sepsis Alliance, the Roy Stoughton Foundation, and other partners. In addition, the Visiting Nurse Association of America, who is one of those partners, has been very supportive in terms of wanting to promote this initiative through their national communications. And there'll be something in the next month or so by the VNAA that really lets all of their association members know across the nation about this initiative. The VNAA has also decided to feature a session at their April National Leadership Conference in this very specific sepsis initiative. So we thank the VNA for their continued support and encouragement of this initiative. We also other state agencies and other associations for applicability and use and benefit. That includes, for example, the behavioral health system in the state. There has been interest expressed to us by oncology practices. We've had discussions with the statewide Senior Action Council that really has this very, very high on their portfolio, and other associations and venues where this tool could be made applicable. There's also continued collaboration with the CDC and CMS and others. So on the CMS side, ICRO continues to be the implementer of the CMS pilot projects in New York, both in the central New York area and the Capital District area, for community screening and recognition of sepsis. That initiative is using this tool in that pilot phase, both in education and in practice, and we hope that the efficacious use of the tool will result in some proactive CMS support for what we are doing on a going forward basis. CDC is also continuing to support this effort. They continue to post and update their web link to our initiative, and also CDC has informed us that they are updating their strategic sepsis plans, and they intend to include in their strategic update an exploration of additional support possibilities for what we're doing here in New York. And they've characterized what we're doing as outstanding pioneering work. So I'm hopeful that those good words will be followed with good deeds and good support for these efforts. We are also looking to garner support in the state budget. They has advanced legislative and budget language that would provide funding and policy support for home care agency implementation of the sepsis tool and staff training. It's the subject of legislation that has been introduced in both the Senate and the Assembly, and we've also provided language to the Governor's Office and the Health Department trying to encourage sepsis support for this sepsis initiative in those efforts. I had a conversation also related to supporting this through the managed long-term care efforts within the state programming. So there are also other entities that are looking to use or model the tool. HCA, IPRO, the National Sepsis Alliance, and other partners are continuing to field inquiries and interest around the country in terms of the use of the tool. I don't think a week goes by that we don't hear from another state, another association, or aspects of the hospital industry in other parts of the country that are looking to model and or use the tool. Right now, in fact, we're awaiting a prospectus from representatives for a major national hospital system that would like to utilize this tool in conjunction with their home care agencies to not only improve the health of their patients, but also to prevent readmissions, targeting on the high-risk categories. So I think a lot of excitement around the country on what's being innovated here in New York. So I think we're really to the conclusion of our presentation. I want to just ask, are there other questions, suggestions, recommendations from literally anyone on the aspect of what we presented to you? We've covered the areas in four webinars. The initial background webinar, sort of a follow-up between the initial one and a bridge to our third webinar, which really focused on EHR integration. For anyone on this call that was not able to follow that, you should go back and make sure that you attend the recording of that webinar. There's really very detailed information and suggestions as to how you can operationalize this within your EHRs. So again, look, the lines really are open to any questions, recommendations, suggestions, or any final comments.
Grace, can you explain again how they can ask questions?
Definitely. So, ladies and gentlemen, In order to ask a question, please press star and the number 1 on your telephone keypad. Again, that's star, then the number 1 on your telephone keypad. Let's pause for a second to compile the Q&A roster.
And just while we're waiting for the next question, I know that we've addressed this in some of the other webinars, but just a reminder that, you know, all of the hospitals in the state, we're working on readmissions and care transitions. So putting that hat on, sepsis is the number 1 for 30-day readmissions for Medicare fee-for-service patients across the state. If you're looking for an opportunity to partner with your hospital or to market with the hospitals that you are referral sources for, this is a great opportunity to be able to share with them that you have the sepsis protocol and you're proactively screening for it and actually can assist them with identifying patients at risk for sepsis, identifying the signs and symptoms. So that's an excellent marketing to share that. Any questions, Grace?
As of the moment, we don't have any questions, so please continue.
Amy, as we're concluding, do you have particular comments or recommendations or any other points that you'd like to stress?
No, I think we have covered most everything over the webinar.
Well, one thing that I would like to do is certainly to acknowledge the tremendous work that's been done in this effort. This has really been a multi-year effort that really began with a query on what is the prevalence level of sepsis in the community? Is there a role that home care can play? It really began at that level and very quickly escalated into a very validated process for a very important role that home care can play. As we've mentioned in prior webinars, over 80% of sepsis cases originate in community, though the common thought is it's an infection that occurs in the hospital, you know, or is only recognized in the hospital. But we know that the vast majority of sepsis cases occur in community. We also know that the high risk populations that are in home health, that are in home care. So we know that we are really at a very critical point in terms of potential intervention with both education and early recognition and prevention. So, you know, we believe that this effort has certainly been very validated along the way. And in terms of acknowledgement, I would start off acknowledging the work that Amy Bowerman has done. The construction of the forum, et cetera, has all been done under her leadership. In addition, we have along the way have had to vet very thoroughly, very carefully the tool, the protocol, the algorithm, and again, that was really done under Amy's leadership. So thank you on behalf of the entire home care community, Amy, for your efforts and your leadership in this whole regard. The article that you penned that was in the Central New York paper really helped to increase awareness and really put this on the media radar as well. Sarah Butterfield and Eve Banker from iPro have really given a tremendous amount of their time and effort and expertise and their leadership to the pilot project with your original participation on the sepsis work group, the quality committee, and in all of these process efforts. This has really been a very, very extensive effort. So thank you, Eve, thank you, Sarah, and thank you, iPro, and also for co-hosting this series of the 4 webinars. I also really want to acknowledge the work of the members of the quality committee of HCA and those that were on the more intensive sepsis work group. We'll be providing acknowledgement time doing the beta testing, providing all the feedback on those initial drafts of what we developed. Lori Neander from At Home Care, Marie DeMont from At Home Care, Shelley Ableton and her staff, Jackie Crester, Kathy Seymour. The list really is very extensive, and if I start continuing to name the names, I'll leave people out, and I don't want to do that. But really, just to let the entire association know of the extensive work that went in at that level. Just two or three more people and organizations to cite. Dr. Martin Dorfler, who is the Director of Clinical Affairs for Northwell, was really a pioneer in working with us. North Shore has been a leader in sepsis early recognition and training and intervention, and we largely we utilized that experience in building this product here. And Dr. Dorfler spent a tremendous amount of his own time and effort in advising. Dr. Stephen Simpson, who's on the national board of the National Sepsis Alliance, also contributed a tremendous amount of his time and expertise, and we were all sort of in the weeds together as we were working through the active details and the wording and the wordsmithing of the tool and the related material. So thank you so much, Dr. Simpson. Tom Heyman, the Executive Director of the National Sepsis Alliance, really was the generator going back to the initial outreach to HCA about sepsis and about harnessing home care's role in sepsis. And Tom and his team, Savannah Stark and his team at the Sepsis Alliance have been with this and promoting this and informing this every step of the way. And also the Staunton Foundation and the leaders of have been very, very supportive of this effort. They featured this effort in a national conference back in September and promoted it and have promoted it as a national blueprint for sepsis intervention. And certainly their passionate work in sepsis has also really energized and informed this effort. The Governor's Office, Paul Francis, the State Health Department, Becky Gray, thank you so much for your support in this whole effort. So I think it's just proper to acknowledge the extent of the work that has gone into this effort. Pat Ruhan also from the State Health Department. So in terms of next steps, HCA will be announcing again imminently the finalization of the user agreement, all aspects of the tool. We'll be providing you with instructions on how to communicate with HCA to register your intent to utilize the tool, and then we'll go from there. With that, we'll also announce, the next steps as it relates to further assistance that we will provide you with respect to implementation. And we'll certainly keep you up to date on all developments with respect to our outreach with CDC, the legislature, and the administration for support of this effort. And I think lastly, Sarah's point, this whole effort is really about the encouragement and the use of this tool and the adoption of this tool at the home care agency level statewide. The extent to which this can be implemented diligently throughout the home care community will really contribute, we believe, to the efforts to intervene and combat in our society, and also, again, help position home care in a very volatile and sort of moving market in an area that where often there's really very little thought to whether this is what a role might be for home care or in the community. This is home care for showing that it's ready to step up and play a very, very critical public health role in the process. And going back to quoting what was part of a keynote address in the national conference that the Stautons had hosted, it's always good when you follow the lead that's been created for you in terms of a mandate or requirement. But at the same time, it really speaks well to professionals who know when something needs to be done, who know that it's the right thing to do, and aren't waiting to be told that they have to do it. But pick up the mantle and go out and do the job that as professionals make a difference in people's lives. Sarah or Amy, any comments? Final?
I think you've done a very nice job.
Yes. Thank you.
And thank you very much, everyone, for your participation today.